Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Han for an interview today. Thank you so much for joining today, Dr. Han.
Well, thank you for having me.
Of course. So today we're very delighted to feature your publication titled New-Onset Conduction Disturbances After Transcatheter Tricuspid Valve Replacement, a Mechanistic Assessment. So Dr. Han, could you please begin by explaining how the anatomic relationship between the tricuspid annulus and the conduction system increase the risk of conduction disturbances?
Yes, of course. The AV node is located in the lower inferior portion of the right atrium, and it's very near the interatrial septum and the coronary sinus. And it sits very, very close then to the tricuspid annulus. From the AV node, then you have the bundle of His that then passes through or runs along the inferior portion of the membranous septum. So because all of this, the conduction system, the AV node and the His bundle, are really close to the tricuspid annulus, then there is a risk, of course, when you're implanting transcatheter tricuspid valve devices that might be adjacent to or putting pressure on that region of the AV node, that you might then have a new-onset conduction disturbance.
Excellent. Thank you so much, Dr. Han, for that explanation. So my next question is that in your paper, you mentioned that 44% of the patients actually developed new onset conduction disturbances after the TTVR, which is very interesting. If you don't mind, if you could explain some of the factors which were independently linked to the development of this conduction disturbances.
Yeah, I mean, it was interesting. Obviously, the study as far as the prevalence of new onset conduction disturbance is might be a little bit skewed by the patients that we ended up studying and having CT scans on. But those new onset conduction disturbances within 30 days of the procedure were associated with a hyperdynamic right ventricular function, and that we detected by the free wall strain on echocardiography. And so it was that absolute very high free wall strain that was clearly associated with it, and we had a number of 29% that was associated with NOCD. And then we also found that on computed tomography that the contact with the subvalvular device with the membranous septum also predicted new onset conduction disturbance. And so we think that the device is actually interacting a little bit with the region of the conduction system, contributing then to the conduction disturbance, but also the fact that we have very hyperdynamic lateral wall function may change the interaction of the device with the membranous septum. So remember, that lateral wall opposite the septum is moving a lot and may actually then cause a little bit of more contact of the membranous septum with the subvalvular portion of the device.
Perfect. Thank you, Dr. Han. So on that note, were you surprised that device oversizing or the thickness of the membranous septum was not actually associated with NOCD?
Yeah, I mean, I think I was surprised that we didn't find a relationship with oversizing, because, again, you would think that the oversizing of the device might lead to more contact with the membranous septum. So a little bit of a surprise. I don't think that the size of the membranous septum itself should necessarily determine whether or not you have new onset conduction disturbance. It's rather where the conduction system runs along that membranous septum. So I wasn't surprised about the membranous septum size. I was a little surprised that we didn't find an association with any type of oversizing. I mean, we looked at a variety of different ways of looking at oversizing, and we couldn't find a relationship. So a little surprising.
Perfect. Thank you again, Dr. Han. So I know this is an area of ongoing research, but do you think the findings of your paper would influence patient selection for TTVR in the future?
Yeah, I think that, we have some main mechanistic theories. I'm not sure whether those theories really at this point should affect the way that we decide which patients should or should not get TTVR, particularly with the devices that we currently have clinically available. But we do want to think about that excessive longitudinal motion of the annulus, or the way that the device may, that we had some signals also for the canting perhaps of the device. We had some signals for other anatomic features like more complex morphologies of the leaflet, which may end up changing the way the device seats itself in the annulus. So it's just hypothesis generating at this point. And I think that although in the future we may decide we've figured out which patients will get conduction disturbances and which won't, I think at this point it's just hypothesis generating, and really should hopefully promote more research into the field.
Absolutely. I hope in the future the research answers these questions even further. But thank you so much for sharing your insights. Thank you so much for joining us today, and congratulations on your work.
Thank you so much. Thanks for having me.